Introduction. So, as I say, as this is going to be, we're talking about murmurs in dogs and cats and the evidence behind what we should do. My plan for this talk is very much going to be, we're talking about the common cardiac diseases, the diseases that you're likely to see on a daily basis, and so they're mostly the acquired diseases. And we're going to go through some clinical cases to just work out how you work up these cases. And we're going to think about why we need to investigate murmurs and how to investigate them. Think about what investigations they need to be performed. So obviously with the common cardiac diseases, with dogs, we're thinking about myxomatous mitral valve disease. You might know it as degenerative mitral valve disease or endocardiosis or mitral valve disease. It's got lots of different names, but I generally will be referring to it as myxomatous mitral valve disease, and you'll see the abbreviation MMVD. And then the other big disease that we see in dogs is dilated cardiomyopathy, or DCM. In cats, we're thinking about the myocardial diseases, obviously hypertrophic cardiomyopathy being the most common of those. And we know that some of these diseases can have a really long preclinical life, particularly mitral valve disease and HCM, but that they can also lead to congestive heart failure. And so knowing that the disease is present and how severe it is can potentially alter how we medicate and manage these conditions. And with that, we can potentially extend life. Now, sadly, not every cardiac patient comes quite so neatly labeled as this particular patient did. And so we're going to have to think about, when we hear a murmur, how we know what's going on. And so if we have Pip, for example, she's come into your clinic and you've picked up a murmur, the first thing you're going to want to do is really focus on exactly what type of murmur that is. So a thorough auscultation and describing the murmur is going to go a long way to narrowing your differential list down. And with that differential list, you can then work out if it's worth doing more investigations. So before we think a lot about her particular murmur, let's do a little bit of a recap on best way to auscultate dogs. So whenever I start an auscultation, I'm always going to want to start with palpation, and what I'm feeling for is, can I feel a thrill? Does the apical impulse feel particularly strong, stronger than I might expect, or is it shifted over from the left to the right? And in little dogs, you can often do that just by putting your hands on. In big dogs, you're sometimes going to need to move your hands around a little bit, and you want to move it far enough forward until your tips of your fingers are almost touching in front of the dog. And then I will feel for where the apical impulse is strongest on my hand on the left-hand side, and that's going to be your left apex. So I'll start there, listen, and then move forward. And I generally talk about moving forward rib space at a time, stopping and having a think. Is the murmur that you're hearing getting louder or quieter? And often you'll need to go up and down the chest a few times until you're comfortable saying it's louder further back, so it's an apical murmur, or louder further forward. Going forward, I think a common mistake that a lot of people make is not going far enough forward for the left base. So for a true left base, you often end up having your stethoscope almost hidden by the dog's triceps muscles. And you want to get right up under there so that you're really listening up at the base. And remember also to go dorsally on the base, because things like your PDA murmurs that you're going to hear as a continuous murmur are actually at the base but quite dorsally. So you want to make sure you listen up and down at the base area. And we're also going to want to do the same on the right-hand side. So we'll listen at the right apex and the right base. Don't forget, whenever you're auscultating dogs, you also want to feel for pulses. You're going to feel, are you feeling deficits? Are you feeling that the pulse quality is very poor? But it's a thing that I think people often forget to do, is feel for the pulse at the same time as auscultating, as well as feeling for the pulses. And with that auscultation, you want to make sure you've made a note of heart rate, rhythm. Is it regular or irregular? Where are the pulse deficits? Presence or absence of a heart murmur, and trying to describe that, as we'll talk about on the next few slides. And then anything else that's abnormal, so other gallop sounds, for example. Rare in dogs, but we do hear them occasionally. For assessing the murmur, the main question is actually point of maximal intensity. Is it at the left base, the left apex, or the right apex? And the right base is obviously somewhere we need to listen to, but it's rare for a murmur to have a point of maximal intensity at the right base. But knowing that a murmur does or doesn't radiate to the right base can be useful in some of the more complex congenital diseases. Obviously, the other key bit of information that's going to tell you what you're dealing with is the timing of the murmur. So is it systolic, diastolic, or continuous? And all of that bit of information is going to tell you basically what disease you're most likely, or what diseases you're most likely to be dealing with. Obviously, the other big thing about any auscultation is murmur grading. And you guys all know we auscultate on a 1 to 6 system. But actually, I generally start off thinking, is this a grade 3? Because a grade 3 murmur is the same intensity as the heart sounds. You put your stethoscope on and it's nice and obvious that it's there. You can still hear the heart sounds if you're in the, even if you're in the best location for hearing that murmur, but it's as loud. If I can still hear the heart sounds and they're more obvious than the murmur, then it's going to be a grade 2. And if it's loud, the murmur is louder than the heart sounds, but I don't have a palpable thrill, then it's a grade 4. And a big proportion of your murmurs are going to fall into that 2 to 4 range. The grade 1s, yes, we do hear them occasionally, but you're going to need a quiet room, a quiet patient, and it takes a really long time to hear. And I am convinced I must have missed lots of grade 1 murmurs when I worked in first opinion practice, because you don't always have the perfect listening conditions. But as we'll go and say, for the most common, particularly for things like mitral valve disease, it often doesn't matter if we're missing the grade 1 murmurs. At the other end of the spectrum, you've got the grade 5 murmurs. So they are as loud as the grade 4s, but you can feel that palpable thrill. And so sometimes when you've got a patient in front of you, if you start your auscultation with palpation, you're going to know it's got a grade 5 murmur before you've ever put the stethoscope on. Grade 6s being louder than the heart sounds, palpable and thrill, and heard without the stethoscope on the chest, they're not common. I have heard a few where I've just taken the stethoscope away from the chest and still been able to hear the murmur. The most obvious grade 6 I've ever heard, I was about 2 meters away from the patient and I can hear its murmur at that time. In first opinion practice, the majority of the murmurs that you're going to hear on a regular basis are the left apical systolic murmurs, and they are the ones that we're going to hear with the common acquired diseases, and so they're going to be the ones that we focus on. But we've got 4 main differentials for our left apical systolic murmur. So we've got myxomatous mitral valve disease, DCM, but we also got mitral valve dysplasia and mitral endocarditis. So we've got when I get the students to try and list out these differentials, I say we've got 2 common diseases and 2 rare diseases that we still need to think about. So if we have a left apical systolic murmur and we're trying to work out, well, which one of those diseases is most likely, age of the patient is a really useful bit of information. Because if you've got a young dog, both mitral valve disease and DCM are really unlikely. So things like mitral dysplasia, which is a congenital abnormality, has to be higher up on the list. But middle-aged, older dogs, all 3 other differentials, all possible. Mitral valve disease, DCM, endocarditis. So then think, well, is this patient in front of me systemically well? Because the endocarditis patients, they're difficult to diagnose, but generally they're not healthy patients when you make that diagnosis. So they may be lethargic, they may be pyrexic, often the murmur is novel, they may have a history of shifting lameness or recent surgery or new wound or an inflammatory picture on their blood work. But it's rare that I make a diagnosis of endocarditis in a patient that's absolutely normal coming in for just screening because somebody's picked up a murmur. These patients are often unwell and they've come to me for investigation of could this be endocarditis. which means the majority of the time, our question is this myxomatous mitral valve disease, or is this left apical systolic murmur because of dilated cardiomyopathy? So what we're going to do is talk a little bit about those two diseases, and we'll think about how we can work out which one is more likely. So I'm sure you remember myxomatous mitral valve disease. It's degenerative disease of the valve apparatus, and it's important to remember it's not just the valve itself, but it's the chordae tendineae as well that are affected with this condition. And it's a progressive disease, and it's a really variable rate. So we see some dogs that go year after year after year, and their hearts don't really change. And then we see other dogs where over a 6 to 12 month period, they go from looking absolutely fine to on the verge of congestive heart failure. And it's, at the moment, we're not very good at predicting perfectly who's going to do which of those progressions. But what we know is that if they've only got a very small leak, that's unlikely to have any significant effect on their cardiac output, and they can have a pretty long life expectancy with that. Whereas if they've got quite a significant leak, that will result in a reduction in cardiac output because a much higher percentage than normal of blood is going across the mitral valve, and therefore less is going out the aorta. And so we get that activation of those compensatory mechanisms, so sympathetic stimulation and RAS activation. So we're going to increase heart rate, increase force of contraction, retain sodium, and therefore retain water. All of those things working towards normalizing the cardiac output, which eventually will lead to dilation of the cardiac chambers and then pulmonary edema. So we'll go from those compensatory mechanisms trying to help maintain cardiac output, but then eventually having deleterious effects and leading towards the development of congestive heart failure. And so we have this screening stage, or this staging system of mitral valve disease, and you're going to see a very similar slide repeatedly as we talk about each of these conditions as we go through. So we have stage A, where they're at risk, and I like to say, well, that's pretty much every Cavalier puppy the minute it's born, but it's also all the small old breed terriers and little dogs that we think about. Then we've got stage B, where they've got the structural disease without clinical signs, which is the group that we're really focusing on today. Congestive heart failure is stage C, either past or present, and then stage D is the refractory heart failure. And because we know that in mitral valve disease particularly, stage B is such a massive group of dogs, lots of them will have a leaky valve without clinical signs. They're broken down into stage B1, where they don't have cardiac remodeling. So those are the dogs with the small leak that are absolutely trotting on fine. And stage B2, where they start to have that remodeling and they've got left atrial and left ventricular dilation, and they're already on that downward spiral towards congestive heart failure. Dilated cardiomyopathy, there are actually two forms of this disease. One is the one that you classically think of, so a dilated left ventricle with reduced systolic function. But we also call if a dog has a structurally normal heart with significant ventricular arrhythmias and it's a predisposed breed, so a Dobie or a Great Dane, they have significant arrhythmias, that will also count them as being DCM. They're very different presentations, and the one that we're going to focus on is the dilated left heart with reduced systolic function, because that's the population of DCM that's actually going to have a murmur, whereas the population with arrhythmias is going to present either that you're going to hear the arrhythmia or they're going to present with collapsing signs. So that's kind of outside of what I'm going to talk about today. But with DCM, if they've got that reduced systolic function, they're already on the downward slope. And so they're similar to the stage B2 mitral valve disease. We're going to start getting reduced cardiac output, compensatory mechanisms, so sympathetic stimulation, RAS activation, all trying to normalize the cardiac output. And then secondary to that, we have fluid retention, dilation of the cardiac chambers, and eventually we'll develop pulmonary edema. So it's that same pathway of reduced output, initially having compensatory mechanisms that help, but that eventually lead to congestive heart failure. And that staging system for mitral valve disease can be adapted to DCM. The big difference between the mitral valve disease and the DCM staging system is that stage B is just stage B. We just have structural heart disease without clinical signs. We can't have a B1 where they don't yet have cardiac dilation because we can't diagnose those patients, they have to have dilation to be diagnosed as having dilated cardiomyopathy. And so it comes on to, well, we know from the auscultation that the patient in front of us is likely to either have mitral valve disease or DCM. What is the point in investigating further? And for me, there are two main reasons why you investigate any murmur. One is because the owner wants to know what's going on and what's causing the murmur. And two is because you want to know, either because you're going to manage that patient differently or you're going to treat them differently. So the questions is, well, will this disease limit the lifespan? The owner's going to want to know that. You may want to know that. Is this patient at risk of congestive heart failure if I anaesthetize them or give them fluid therapy? And can I do anything that potentially will extend the lifespan? And if the answer is that no matter what you find, you're not going to do anything differently, well, then there's not necessarily an argument for investigating further. So hopefully I'm going to convince you over this talk that, well, there is things that you can do. There are things that you can change by investigating further. And so if we think about the evidence, because that's the main kind of focus for this topic. So for the stage B1 mitral valve disease dogs, remember these are the guys that they have the leak, but they have normal cardiac dimensions. We know that many of them are never going to progress to heart failure, but some will, so we're going to have to think about monitoring them. But more than 50% of them are going to die a non-cardiac death, which means that for a lot of dogs with mitral valve disease, this is something that they're going to live with and that they may never run into any problems with. And so we don't consider that we need to treat them at this stage. And so there's not really been a lot of focus looking at treatment options, but certainly at the moment, there's no recommendation for treating a stage B1 dog. And we don't consider them to have significant anaesthetic or fluid therapy risks either. Conversely, the stage B2 dogs, so they have they have at least some atrial or ventricular dilation. They are already on that slippery slope down towards congestive heart failure. And therefore, particularly if they're younger patients, that's likely to limit their lifespan. So knowing is it B1 or B2 can give information about whether it's the patient's lifespan is likely to be limited. And there have been investigations into quite a few different treatment options, and some of them have shown that they'll delay the onset of congestive heart failure. And the big the big study and the big drug that we all think about using is pimavendin, and that's on the basis of the EPIC study, which was published 4 years ago now. So it's something that's we're kind of very comfortable using. And the big the headline graph from that paper was this one. It showed that if you took a dog with stage B2 mitral valve disease and randomized them to either get pimavendin or placebo, the dogs that got pimavendin on average lived another 3 and a bit years, whereas the dogs that got placebo lived on average just another 2 years. So we were giving them an additional 15 months of preclinical life by giving them pimavendin. The study also showed that the pimavendin causes reverse remodeling, so we have that reduction in cardiac dimensions, so it's trying to slow down that process. One thing I should remind you is that although, yeah, there are definitely different brands of pimavendin out there, that Vetmedin is the only one that's actually licensed for use in the preclinical phase. All of the others are only licensed for once they go into congestive heart failure. But for us, EPIC made a massive difference to how we treat these patients. And so now we're seeing a lot of patients with suspected mitral valve disease asking, is it a B1, so I don't need to start treatment, or is it a B2, where I do need to start treatment? Lots of other drugs have been investigated. So ACE inhibitors have been investigated in stage B2 mitral valve disease. And there have been 2 big studies, and neither of them showed any survival benefit compared to the placebo group. So we don't tend to recommend the use of ACE inhibitors in preclinical mitral valve disease because we don't think it's going to help. It's an additional cost to the owner. Beta blockers are an interesting one, and not one that I think we'd automatically think of as being a drug that we would want to use. But actually, beta blockers are used quite frequently in a lot of human cardiac conditions, and so we've investigated them for mitral valve disease as well. And there was one study that looked at a beta blocker we don't tend to use very much in veterinary medicine. It's a drug called carvedilol. And it showed, yeah, it was tolerated. But some dogs did develop systolic dysfunction because beta blockers are negative inotropes, which isn't great when we think about that spiral of reduced cardiac output. And no study has demonstrated any survival benefit for the beta blockers or anything that's prolonging the preclinical period. So again, not a drug group that we tend to use very much in stage B2 mitral valve disease. The final group that's been investigated is spironolactone, and that was very much for the anti-aldosterone effects, the kind of all of those kind of things that they thought might help with remodeling. And the study was underpowered, sadly. It was a small study, but it did show that there's no difference in the cardiac dimensions over time when compared to giving placebo. So if we're thinking purely about what the evidence is, the only thing that we know that we're going to do differently if we diagnose a stage B2 mitral valve disease patient is start pimobendan. For dilated cardiomyopathy, we know that as soon as we've made that diagnosis, they're already on that downward spiral towards congestive heart failure. And so just making the diagnosis says that they're likely to have a limited lifespan. But again, some treatments have been investigated, and again, some of them have shown a delay in the onset of congestive heart failure. And again, it's our big hitter, pimobendan. So this was the PROTECT study. And the PROTECT study showed that if you took Dobermans and diagnosed them with preclinical dilated cardiomyopathy, randomized them to either get pimobendan or placebo, the dogs that got pimobendan, on average, lived about 2 years before they developed heart failure, whereas the placebo group was just over a year. So we get an extra 9 months of preclinical life, which for a large breed dog with dilated cardiomyopathy is a decent addition to their lifespan. It also, as with the mitral valve disease, EPIC studies showed that the pimobendan causes a reduction at cardiac size. The big problem is that it only enrolled Dobermans in this study. So we know it works for them, but we also know that dilated cardiomyopathy from breed to breed, there's quite a lot of variation in what their hearts look like, how they function. And we haven't got studies looking at preclinical pimobendan in any other breed. There was a study there is a study as far as I'm aware still trying to enroll dogs, but I haven't yet seen any other results. So for now, we have to extrapolate the results of the PROTECT study to other breeds with dilated cardiomyopathy. The other class of drugs that has been looked at in DCM are the ACE inhibitors. And actually, there was one retrospective study, again of Dobermans, which did show a small survival benefit. It wasn't nearly as startling a difference in survival times as the pimobendan studies did, and it was performed pre-pimobendan. So we don't really know, nobody's looked to see if the addition of an ACE inhibitor on top of giving pimobendan is useful. The other problem is it was a retrospective study, so we don't know why some dogs received an ACE inhibitor and some didn't. And we haven't yet had any prospective studies looking at ACE inhibitors. So although there is this mild benefit from this retrospective study, most people don't feel that ACE inhibitors have a significant benefit to the preclinical life of DCM patients. So they're not routinely used. So let's come back to Pip. We now know that if we investigate further with her murmur, we diagnose her either with dilated cardiomyopathy or stage B2 mitral valve disease, we're going to do things differently with regard to treatment. We may well think about her anaesthetic risk in a different way. Whereas if we diagnose her with stage B1 mitral valve disease, we're going to be quite comfortable carrying on life as it is for now. So how do we work out? Well, actually that murmur and some things about her can tell us what's more likely. And if she'd been a Cavvy or a Jack Russell, we'd have been all saying, oh, she's got mitral valve disease. Whereas if she was a Great Dane or a Dobie, we'd have been saying, well, yeah, she's obviously got dilated cardiomyopathy. And in general, it is true that small breed dogs get mitral valve disease and big breed dogs get dilated cardiomyopathy. But we're dealing with biology and we're dealing with life, and it's never completely that straightforward. And there's at least one caveat that's in a dilated cardiomyopathy case series, for example. There's also some dogs that just don't play by the rules, and German Shepherds are one of those breeds, in that although they're big breed dogs, we very rarely diagnose them with dilated cardiomyopathy. We do quite commonly diagnose them with degenerative mitral valve disease. And frustratingly, Cocker Spaniels are a population of dogs that get both mitral valve disease and dilated cardiomyopathy. So in Pip's case, we're not really any further forward in working out what's more likely for her. We can think about the murmur itself, though, and try and work it out. So we know that with mitral valve disease, they have a murmur because they have changes to the valve. Whereas with dilated cardiomyopathy, they have the murmur because they have progressive enlargement of the cardiac chambers, and that eventually leads to the mitral valve annulus being stretched and dilated, and therefore the valve leaking. Which means you should have a history in a patient with mitral valve disease, generally have a history where the murmur has been detected year after year at vaccine appointments, and that murmur is gradually getting louder as the disease progresses. Now, I said earlier, sometimes these dogs progress very quickly, but it would be unusual for a DCM murmur to be persistent for year after year after year. It's generally a murmur that's going to appear right at the end of the disease process. So if you hear the murmur today and it was picked up a year ago and it was just a bit quieter, that patient's much more likely to have mitral valve disease rather than you've picked up the murmur for the first time where it could still have DCM. So you know that the patient either has mitral valve disease or DCM, or you've got a bit more of a suspicion based on their breed, what the murmur sounded like in the murmur history. There's a few other things that can say, well, which cases do I really push to investigate? And so for the mitral valve disease patients, if you're convinced that's what it has, if it's a cavity and you're like, it's got to have mitral valve disease, if it's only got a grade 1 or grade 2 murmur, that disease is quite likely to be early, and that patient is more likely to be a stage B1 patient. So if you have an owner that's financially limited and really doesn't want to do investigations unless they absolutely have to because they're definitely going to make changes, then if you've got a quiet murmur, I probably wouldn't be pushing for investigations quite so much in that patient. Whereas if it's a louder murmur, so a 3 or above, it's more likely that they have advanced disease and they could well be at a stage B2 where they've got cardiac dilation and we're going to start treatment. Or it could just be that they're stage B1 and that murmur jet is pointing at just the perfect angles so that your stethoscope is really picking it up. If you're more convinced that the patient is likely to have dilated cardiomyopathy, the murmur grade doesn't really correlate with disease severity, so it's less useful for you to work out whether you really need to push that owner for investigations or not. And do remember that you'll have some dilated cardiomyopathy patients that just don't have a murmur because they haven't yet got to the stage of having the sufficient cardiac dilation to stretch that mitral annulus. So even if you don't hear a murmur, just keep it in the back of your mind for some of those large breed dogs like your Dobies and your Great Danes. The other thing that's important is the heart rate and the heart rhythm, and that applies to both patients, and that's to do with the fact that irrespective of which disease they have, as their disease progresses, they're going to get sympathetic stimulation. So if you're hearing a pronounced sinus arrhythmia, that patient is likely to be very parasympathetically driven, and so they are unlikely to be on the verge of congestive heart failure. So again, if you've got a patient where the owners are financially limited and you're hearing a pronounced sinus arrhythmia and the dog as well, you probably don't need to rush into investigations immediately if the owner can't afford it. If you're hearing a sinus rhythm or a sinus tachycardia, or if you've picked up that actually the heart rate today is much higher than it's been on previous appointments, that patient could now be sympathetically driven because they've got advanced remodeling, or it's just an anxious patient, and having a history of knowing what they're normally like with you can be useful. So knowing how the heart rate has changed can make you say, well, actually, I'm more worried because their heart rate's gone up over time, and now it's much faster than it used to be, so maybe they have progressed. So if we think about what further investigations we're going to need to do to work out, is it DCM, is it mitral valve disease? If it is mitral valve disease, what stage is it? Gold standard is always going to be echocardiography, and I will go through some images and show you what we're looking for with echocardiography. But at the end of the day, I appreciate not everybody is comfortable getting those advanced images, and not everybody feels comfortable even playing with ultrasound. So we'll talk about what else you can do to try and increase your index of suspicion, other tests that you can do. But we'll start off with our gold standard, which is going to be echocardiography. So I have got on the screen 2 echo loops. We have a left atrium, a left ventricle, and a mitral valve. And the key difference between the image on the left, where you've got myxomatous mitral valve disease, and DCM, was a few things. One is that you can see that the left ventricle is pumping really well in the patient with mitral valve disease, and it's not with the patient with DCM. What I am picking up here is that I'm not sure that these echo images are coming across very well. I sent all of these echo images to BSAVA this morning, so they'll be putting those up. So if you can't see the images, I apologise, and we'll make sure that they're well labelled and you can look at these video loops later on. But the key things that I'm looking at is, one, how much the left ventricle is moving, and in a patient with mitral valve disease, it's moving really well. And in a patient with dilated cardiomyopathy, it's not moving. The other thing to look at is the mitral valve. And so when we've frozen those images, we've got our left atrium here, left ventricle, and our mitral valve. Where I've put the line is it's a marker from where the hinge points of the 2 mitral valve leaflets are. And the big thing to notice is that in the mitral valve disease patient, which is the one on the left, the mitral valve is bowing back into the left atrium. So it's prolapsing. That's our diagnostic criteria for having mitral valve disease. Whereas our patient with dilated cardiomyopathy, yes, the mitral annulus is a bit stretched, but the leaflets themselves are normal, the chordae are normal, and so the valve leaflets are meeting beautifully in front of the left atrium. The other thing that we'll be looking at is the jets of mitral regurgitation. So for a dog with mitral valve disease, you'll often have multiple jets that are going all over the place, whereas a dog with dilated cardiomyopathy, you'll often have a single central jet. The other big thing that we're going to think about, as we've talked about, is looking for the progression of the disease. So we're going to want to look at left atrial size. And if there's only one thing that you're going to look at is left atrial size, that's probably the most key thing for knowing, has this disease progressed? And so we can again use echo to assess left atrial size. So we have a normal patient on the left and a patient with significant left atrial dilation on the right. And we have the aorta in the middle of each of those images, is that circle, and we can look at how big the left atrium is compared to the aorta. But not everybody has access to echocardiography, and it's looking like from this talk that none of you can see my echocardiographic loops anyway, so I apologise about that. But we can think about doing something else to try and work out what's going on, and thoracic radiographs are a good option. But we have to remember that what we can't do is make a diagnosis of either mitral valve disease or DCM purely on radiographs. You have to go in knowing, I think this is more likely to be mitral valve disease or more likely to be DCM. You can't actually say for definite which one it is. What you can do, though, is say, does this patient have a big heart? And we know that either the dilated cardiomyopathy patients are going to have a big heart, and the stage B2 mitral valve disease patients are going to have a big heart. So we know that we can pick out the ones that we're going to need to treat based on thoracic radiographs if you're not comfortable with echo. We just can't say which disease they're likely to have. And we can do either vertebral heart scores, or we can make a more subjective assessment, and we'll go through a radiograph looking at both of those techniques. So this is a right lateral radiograph from a dog. I actually can't remember. I think she had dilated cardiomyopathy, but I can't remember. It doesn't really matter though. So if you're doing that vertebral heart score, you're going to want to draw a long line on the long axis, and your markers are going to be from the ventral border of your left main stem bronchus at the top, all the way down right to the bottom of the longest mark, and that's your long value. And then you're going to want to put a second line on the screen at 90 degrees, somewhere in the middle third, that's at the widest point of the heart, and that's your short measure. And then you're going to put both of those onto the vertebrae from the fourth thoracic vertebrae and measure how many vertebrae it takes up. And in this patient, the long is 7 and the short is 5.2. And our vertebral heart score is the long plus the short, which for this patient is working out at 12.2. And we know that normal is 8.7 to 10.7. So for this patient, we can say, based on our vertebral heart score, that they have a big heart. And if this was a Dobie, we'd be saying, okay, well, and it's got a left apical nerve, we'd be saying, all right, this patient has dilated cardiomyopathy. I'm worried enough that it's got a big heart that I'm going to start pimavanserin. Or if it was a cavy, say, okay, I think it's got mitral valve disease. And the fact that it's got a big vertebral heart score means I'm going to take it more seriously and start pimavanserin. In honesty, I very rarely actually spend time doing a full vertebral heart score, and I spend a lot more time just doing a much more subjective assessment. And the one thing that I do, if I'm just being quick about it, is I draw a line from where the caudal vena cava is coming into the heart up to where the main stem trachea is bifurcating. And I should expect to not see any heart above that line. And so in this patient, all of that area above that line is left atrium. So I can look at it and just say, okay, I know I've got a big left atrium, therefore this patient has a big heart. Sometimes you don't need to do any of that at all. Sometimes it is super obvious. So for example, this is one of our cavaliers he's getting towards, he's actually been in heart failure and he's stabilized on medication, but his heart is absolutely massive. It's taking up a lot of space in the chest, pushing his trachea up. If I were to do the measurement with that line across, I'd see a massive left atrium of the line. Yes, if I were to spend time doing a vertebral heart score, but I don't need to because I can just look at that and say that's huge. Another option we've got are our cardiac biomarkers. And so we've got NT-proBNP, which is the biologically inactive segment that's cleaved from BNP before it can often be biologically active. And that BNP is released in response to myocardial stretch. And we've also got troponin, which is involved in regulating the actin-myosin filaments interactions within the myocyte. And therefore, it's only going to be released if you've got myocardial cell damage. And using cardiac biomarkers can increase or decrease your index of suspicion for progressed cardiac disease. But I can say they shouldn't be used to make treatment decisions. There's so much variation, and I'll show you in a couple of slides the amount of variation there is for patients, which means that we can't use a single number to definitively say that patient needs to start treatment and that one doesn't. But what it can be used for is to select which patients should have further investigations. So you can start it off as an initial screen and say, okay, I'm happy with you. I don't need to investigate further. Or, yeah, actually, I think I need to do more investigations in you. And the biomarkers went through a phase probably about 10 years ago where everyone was really excited by them. So there were lots of different studies and they've all published slightly different cutoffs. But actually, IDEX have a set of cutoffs that work for a lot of dogs. And that is that if the NT-proBNP is less than 900, they're unlikely to have clinically significant stretch of the myocardium. Now, the one breed where they make a note, actually, if you ever send to IDEX, you'll see that Dobermans have a slightly different cutoff. And they say that Dobies, If you get a value above 735, then those patients you need to think about investigating because they're much more likely to have DCM. But I mentioned there are lots of breed variation. So, for example, we've got our cavies and our daxies and our Dobermans that all fit mostly below that 900. But, for example, at the other end of that graph, we've got Labradors and Newfoundlands, and they have much higher values. And so a cutoff that works for a Daxi isn't going to work for a Labrador. And then we have published in the last few months in JSAP this paper looking at Labradors and healthy Labradors and normal variation in NT-proBNP. And we've got 50 odd Labradors, and we showed that so each one of these lines on the graph is an individual dog, and the red line on there is that IDEX 900 cutoff. And for some of the dogs, that cutoff is going to work beautifully. So the dogs on the left of the line, great. If you get a value of above 900 for that patient, you know that there's concern because their normal is below that number. But some of those dogs are routinely sitting in the 1,000, 1,500 up to 2,000 values. And so you could mistakenly say, I'm actually worried about that patient when you don't need to be. And some of them cross the line. So on one day they would have been below 900, and on other days they're above 900. And it just depends which day you were. So we recommended that healthy Labradors should be considered normal with their NT-proBNP up to just over 2,000, which is very different to the IDEX cutoff. So you do have to bear that in mind. And I suspect over time there's going to be more papers looking at different breeds. So definitely biomarkers are a great screening tool, but just be aware that sometimes you need to think about what the breed is. If you're getting a result that's a bit unexpected, either speak to IDEX or find a cardiologist and just say, what's your experience of this breed? Now, I'm not going to be able to tell you what the Labrador cross Poodle cross Jack Russell NT-proBNP should be, but the more common breeds we're definitely going to start to get a feel for over time. So bringing all of that together with mitral valve disease, if you can get to the point where you're convinced this dog has a stage B1 disease, whether you've echoed it, whether you've taken radiographs, however you've got there, we don't recommend any treatment because we don't think that there's enough evidence out there to support the starting of treatment. And we don't think there are significant anesthetic or fluid therapy alterations required. Whereas the stage B2 dogs, we're going to recommend that you start treatment with pimobendan and that you get the owners to start monitoring sleeping respiratory rates at home. And we talk about normal being less than 30 breaths a minute. And we say that we're concerned that they're developing heart failure if that breathing rate is trending upwards or it's persistently above 40 breaths a minute. We would also recommend that if you're stage B2, that you're cautious with your fluid therapy. Think about whether you really need to do that anesthetic, whether they really need to be on fluids. And if you do need to anesthetize them, avoid the alpha-2 agonists, particularly if they've got significant atrial dilation. And there's two reasons for that. One is that the alpha-2 agonists cause vasoconstriction, which means they'll increase blood pressure. And therefore, if you are a red blood cell sitting in the left ventricle and suddenly your afterload goes up because the blood pressure has gone up, it's going to be much easier for you to go back into the left atrium. So you get a lot of worsening mitral regurgitation when you give an alpha-2. You're also going to create bradycardia as a reflex to that vasoconstriction and that increase in blood pressure. And that drop in cardiac output will often result from a bradycardia. So you can push a patient into heart failure by giving them an alpha-2 agonist if they were on the brink. And then my recommendations for in-clinic assessment would be think about tracking that murmur grade. If the murmur grade suddenly goes up at the next vaccine appointment, maybe you need to think about reassessing, even if you only assessed them quite recently. Track the heart rate and rhythm over time, because that will give you a feel if they're heading towards being very sympathetically driven and knowing that they're heading towards congestive heart failure. And think about repeating your imaging. So if it's a stage B1 dog, 6 to 12 months, most of them I do every 12 months rather than every 6 months, unless I'm worried that they're bordering on to stage B2. But I want to check the B2 dogs slightly more frequently, mostly because I want to see how quickly they're changing now that they're on that helter-skelter going down towards congestive heart failure, to get a rough feel for how quickly things are likely to go wrong for that patient. If you are convinced that that patient has DCM, great. But DCM is not as easy as mitral valve disease to diagnose. And if it's obvious, great. You've got a big dilated ventricle that's not doing very much. But we do see a lot of DCMs where we have to do quite a lot of measurements before we say, yep, that patient has DCM. So if it's not obvious, I don't think it's ruled out in a lot of patients. And so then your question is, well, what do I do? And for some owners, they're willing to go down the route of referral, but lots aren't. And I think if you have a patient where you're not sure what's going on, I think just assessing the risk for imminent congestive heart failure. So is it a big atrium? If it is, who cares what the left ventricle is doing? If the owners don't want to pay for more investigations, you want to say, does this patient have a big atrium, or whether that's radiographs or echo, whatever you feel more comfortable with, because at least you can get them starting to monitor things. The other big problem with DCM is there are lots of other things that look like DCM. So there are things like tachycardiomyopathy. So if you have a heart rate that's persistently 250, whatever, really fast, over time that's going to exhaust the myocardium and cause systolic dysfunction. We occasionally see myocarditis where we get inflammation of the myocardium, and we often don't know why they get that, but it can often look like DCM. Recently, there's this boutique exotic or grain-free diet, so breeds that are unusual who are developing DCM, and it's been linked back to certain diets. And at the moment, there's still links being investigated. But if they have that, we know that that's potentially reversible. So it's I always now get a diet history from DCM patients. And then another diet-related condition, American Cocker Spaniels will get taurine deficiency that will mimic DCM. And again, if you identify that they're taurine deficient, you can reverse those changes. Hypothyroidism is the final one that might mimic DCM, and we're not totally sure yet if that's true or not. There's definitely some associations, but the jury's still out. So for a DCM patient, I'm going to want to do a 24-hour ECG Holter monitor to look for any sustained arrhythmias that might be causing the changes. I'm also going to want to look for arrhythmias that could be secondary to the DCM. I'll run a troponin to assess for myocarditis, and I'll ask them what their diet has been. For taurine measurements, definitely for American Cocker Spaniels, but I'm not so sure that I bother with other breeds because to be honest, it's a difficult thing to measure. There's not very many labs that do it. It often has to be sent on ice, and if I'm not expecting to get an abnormal result, sometimes it's easier to just not do it. And thyroid function I'll only really assess if there's compatible clinical signs. So if I've got to a point where I've made a diagnosis of DCM, I'm going to start treatment with PIMO. And again, monitoring sleeping respiratory rate and effort, with normal being less than 30, and I'll be concerned if it's trending upwards or above 40. The one big caveat there is these guys. So Dobies, I have seen multiple Dobermans in congestive heart failure with what I would consider a normal respiratory rate. They have increased respiratory effort, but not necessarily always increased respiratory rate, and so they can really trick us into thinking that actually everything is mostly okay. So I'd pay big attention to keeping an eye on your Dobies. If they've got DCM, we're going to want to be cautious with fluids and avoid the alpha-2s, just like we are with the mitral valve disease patients. Again, that vasoconstriction increases afterload and therefore decreases output, and the bradycardia will decrease the output. For my in-clinic assessment, the murmur, as I've said, doesn't mean so much, so it's more about tracking the heart rate and the rhythm over time, and repeat imaging and 24-hour ECG Holter monitoring, generally on a 3 to 6 month basis. Moving finally on to cats, they are not easy. And there's a few big differences to auscultating cats compared to auscultating dogs. Similar things, obviously, you need to assess heart rate and rhythm, assess do they have a murmur, what grade it is, what the timing is, what the point of maximum intensity is, and whether they've got gallop sounds. So from that point of view, what you're asking is the same. The big difference is how you auscultate cats, because cats' hearts are small. And if you compare the size of most cat hearts to either your adult stethoscope or a pediatric stethoscope, you can pretty much cover the entire heart of a cat with your stethoscope, which means that you're not going to be able to make the neat little apex versus base differentiation. So just like with dogs, I'm going to start with a palpation of the cat, and then I start high up on the left-hand side. But unlike dogs where I'm moving backwards and forwards along the chest, I'm actually going to move down. So heading down towards the sternum is going to be the most useful thing that's you to do. And you keep going round until you get right to the bottom of the sternum and come up the other side. And that's because the point of maximum intensity in cats, you can describe it as left-sided, left parasternal, right parasternal, or right-sided. But actually, the vast, vast majority of murmurs are either left or right parasternal. And so if you only auscultate on the left and the right, and you don't go anywhere near the sternum, you're going to miss a lot of those murmurs. If we think about, okay, we've heard a murmur, well, what could that be? The one thing to remember is that if you listen well, 40% of apparently healthy cats have a murmur picked up, which is a huge number of cats. And a lot of them are just innocent flow murmurs, but some of them are going to be due to myocardial disease, and some of them are going to be due to congenital disease. And just listening, you don't really know what you're dealing with there. But one thing we can say is that congenital disease isn't common, but it can be missed. So we do occasionally make the diagnosis of a congenital disease in an adult cat. But mostly what we're thinking about is this an innocent murmur, or is this a murmur due to myocardial disease? So if we think about the feline myocardial disease, I've been very vague, and often we think about hypertrophic cardiomyopathy when we think about the feline myocardial diseases, and HCM is definitely the most common disease that we see. But there is also restrictive cardiomyopathy, dilated cardiomyopathy, arrhythmogenic right ventricular cardiomyopathy, and then the catch-all term of non-specific phenotype. And this is laid out in such a way is because actually they're not neatly defined at all. Yes, what looks like classic HCM is what we see often, but we know from studies that if you give the same echo loop to a group of cardiologists, different cardiologists are going to call it different things. Or if you take the same cat and scan it on repeated times, even the same cardiologist may call it different things on different days. And so there's massive overlap here, and it doesn't necessarily matter which one it is. We'll talk about, really, we're only interested in knowing whether we need to be worried about that cat, not whether it has a little bit of hypertrophy somewhere in its heart. So if we think about working out our differentials, is it innocent? Is it myocardial disease? Point of maximum intensity, not useful. Neither of them, both of them are just common at the sternum. Doesn't help you at all. And the majority of feline murmurs are dynamic, which means they're coming and going, or they're getting quieter and louder. And that's almost all innocent murmurs, but more than 80% of myocardial disease murmurs. So again, the fact that the murmur comes and goes, not so helpful. We can say that the murmur grade in cats that have got myocardial disease is higher than the murmur grade that cats that have innocent murmurs, but there's massive overlap there. So both innocent murmurs and murmurs due to myocardial disease can be anything from a 1 to a 4 out of 6. And so if we just use, has this cat got a murmur or not, to try and predict whether it's got a heart disease, well, that has a positive predictive value of just under 30%, which means that for every murmur you listen to in a cat, only 30% of them actually have heart disease. And a negative predictive value of just over 95%, which means that if you can't hear a murmur, 95% of the time, great, cat doesn't have heart disease, but 5% of the time it does. And that is influenced by age, which means that your positive predictive value increases with age. So I take a murmur much more seriously in an old cat than I do in a young cat. Unfortunately, the negative predictive value decreases with age. So in a young cat, if it's not got a murmur, great, it's really unlikely to have heart disease. But in an older cat, even if it doesn't have a murmur, you still have to have it right at the back of your mind, could this cat have heart disease? So murmurs in cats, really frustrating because they're not that helpful in actually telling you what's going on. If we just do a very quick wrap up of the myocardial diseases. So hypertrophic or restrictive cardiomyopathy, both diseases are diastole. Dilated cardiomyopathy, arrhythmogenic right ventricular cardiomyopathy, both diseases of systole. And that catch-all bucket of the non-specific phenotype, either systolic or diastolic dysfunction, both can be present. It's the I don't know what to call it cardiomyopathy, really. But it doesn't really matter which one of those categories it's in. They can all lead to atrial dilation with reduced atrial function, which means that they can all lead to congestive heart failure, arterial thromboembolism, and all lead to sudden death. So it doesn't matter which three-letter acronym you give the cat, if they've got a disease that's progressed far enough, it's got atrial dilation, then they could be at risk for these complications. And so just like the mitral valve disease staging system, they've now put out a feline consensus statement, and they've done this A to D grouping. The big differences are that in the stage C patients, arterial thromboembolism also is in stage C. But like the mitral valve disease patients, they've subdivided them into the B1 with no cardiac remodeling and B2 with cardiac remodeling, particularly left atrial dilation. So back to that question, why should we investigate that murmur? Well, obviously, the first question is, does this cat actually have disease? You can't tell just by listening, unlike with a dog where you know if there's a murmur, then it's got disease. The investigations are useful to say, will it limit the lifespan? If that cat has a massive left atrium, that's going to tell you and the owner it's going to limit the lifespan, and it will mean that it's at increased risk of congestive heart failure if you anesthetize them or give them fluids. We can ask, will any treatment change the clinical course? Unfortunately, this is the big difference between cats and dogs. Because if we think about the evidence out there, sadly, cats are lagging far behind dogs with regard to good clinical evidence for what will work. So the first drug that was investigated for cats, or the first drug that I'm going to talk about, is diltiazem. And the reason I talk about it first is it's actually the only one that's licensed for use in preclinical HCM. And yet, there is a single study with 5 cats that showed that if you gave them diltiazem, there was no change in their echo measurements over 3 to 6 months. Wow, it's great in a disease that can last years and years before it makes any change. For me, that's not good enough evidence to start giving a cat a pill 3 times a day. And no study has shown that diltiazem prolongs the preclinical period or gives any kind of survival benefit. So it's not a drug that I use for preclinical HCM. The only time I'm going to use diltiazem is if I need it as an antiarrhythmic. Lots of other drugs have been looked at. ACE inhibitors have been investigated. In fact, there were 2 studies in ACE inhibitors, and neither of them showed any benefit to the cats from an echocardiographic point of view. But no study has looked at whether cats with preclinical HCM benefit from treatment with ACE inhibitors from a survival point of view, so we just don't know, but it doesn't seem likely. Beta blockers is a more controversial area, and that's because it's used routinely in human HCM patients, and it's mostly used when they have something called dynamic outflow tract obstruction. So that is when the mitral valve is moving in an abnormal way, and one of the mitral valve leaflets gets in the way of blood leaving the left ventricular outflow tract up to the aorta, so it obstructs the flow. And we know that in people, that obstruction causes chest pain, it causes syncope, and it causes them to drop dead. So therefore, it used to be that veterinary cardiologists said, well, okay, if it works in people, we'll give it to cats. And absolutely, it does reduce the obstruction. And then there was a retrospective survival study, and I've already mentioned earlier on the difficulty of using retrospective studies to make treatment decisions. But that study showed no survival benefit at all for the cats with HCM. And even when they just looked at the cats that had outflow tract obstruction, no survival benefit for these cats. So it really highlights that we have to be quite cautious just extrapolating from human medicine without thinking about our patients in different ways. We've now found that there's no link between outflow tract obstruction and cats and sudden death. So unlike in people where it's a big cause of mortality, it doesn't seem to be the same in cats as far as we can tell. So there's definitely a difference there. What I don't know, and I don't know that many of us can say, is whether cats get chest pain. And I've certainly seen 1 or 2 cats where they stop and pant and they've got severe outflow tract obstruction, and I worry that they've got chest pain. And for those cats, I might think about beta blockers. And again, if they're syncopal, I might think about beta blockers, but I don't think it's now necessarily the go-to drug for cats with hypertrophic cardiomyopathy, not least because you're going to need to give it as an owner twice a day, year after year after year, in a disease that may never actually cause the cat any clinical concern. Other diseases and other treatment options, well, nobody has looked at pimobendan at all to say whether it helps in feline myocardial disease, although if you look in the formulary, it says don't use it in hypertrophic cardiomyopathy. And that's because you don't want to, if they have got obstruction to blood flow, you don't want to increase the force against that obstruction. And actually, no study has demonstrated that any therapy will slow the progression or improve survival time in cats with preclinical myocardial disease. So it's not looking like actually there's a huge amount of evidence that we're going to change anything treatment-wise by knowing what's going on with this cat. But we've all, I'm sure, had the experience of anesthetizing a cat for a dental or something, and then it going into heart failure 24 or 48 hours later. So we still need to know what we're dealing with when we're anesthetizing or giving fluids to a cat about their risk. And actually, there is one drug that a lot of cardiologists will use in preclinical hypertrophic cardiomyopathy, and that's clopidogrel. And that's not because there's any studies at all in the preclinical period, but there is the fat cat study, and the fat cat study is the feline arterial thromboembolism clopidogrel aspirin trial. It's one of my favorite acronyms from veterinary medicine. And that looked at cats that had enrolled cats that had already survived one thromboembolism. So they're no longer preclinical. They've had an arterial thromboembolism and they've survived it. But it showed that if you have had a thromboembolism and you get clopidogrel afterwards, you're going to live a lot longer before you have another thromboembolism than if you get aspirin. And we're talking just over 400 days to just under 200 days. It's a massive difference in survival time. So there's definitely some evidence that clopidogrel helps these cats. And basically, we've extrapolated that to our preclinical patients, because once you've seen a cat with an arterial thromboembolism, if you could have gone back and done anything different to try and prevent that, you will do. And so we're looking for the cats that we think are high risk. So the cats that have the big left atrium, the poorly functioning left atrium, the spontaneous echo contrast, all of those cats, we're going to say, right, let's start treatment, even though we've got no evidence. So if we go back to our cat that's come in with its asymptomatic murmur, I think it's obvious that the further investigations we're going to need to do is echocardiography to find out what's going on. And again, these videos are available for you or will be available on the BSAVA website. But what we've got is a normal cat versus a cat with hypertrophic cardiomyopathy. And I'm showing that sometimes it's really obvious what the difference is between a normal and a hypertrophic cat. But I want to make it clear that sometimes it's really not obvious, and that some of them can be very subtle. We can look at assessing systolic function. So the cat on the left has got an area just down here that's really thin and doesn't move, and you'll see it as a video that that area is just not moving at all. We can also assess diastolic function. We can assess for whether they've got outflow tract obstruction or not, and that we can do that with Doppler. So there's lots of things that we can do with echo. But if you're not comfortable, it took me a while before I was really comfortable doing cat echoes. Actually, the big question is not, does they have a bit of hypertrophy somewhere? It's, are they the cat I really need to worry about? So if we compare the cat on the left, where we've got the aorta in the middle of the screen and the left atrium below it is a very tiny structure, great. That cat looks fine. I don't need to worry about its risk. Cat on the right, pretty small aorta up at the top, and that's because the left atrium is that massive black structure that's taking up all the space in this echo image. So that cat I'm really worried about. Problem is, which cats do we actually investigate? If I've told you that 40% of cats have murmurs, we can't investigate them all. We just don't have the time. And so one thing that I did as part of my PhD is I was looking at how we try and answer that question. So there was a paper called the CAT scan paper. And we found that if you're male, if you're older, if you have a louder murmur and you're overweight, you're much more likely to have hypertrophic cardiomyopathy than if you're not. But obviously that picks up some, but it doesn't pick up all of them. So other things that I would think about investigating or having in the back of your mind: do they have a family history of cardiac disease? We see it running in families all the time. Can you hear gallop sounds or arrhythmias? Because both of those things tell us that the heart is much more unhappy than normal. Can you feel that the apical impulse is really, really prominent? And I'd also look to see, can you see jugular pulsation? So jugular pulsation, we don't see it very often, but when we clip up for blood sampling, I always check for it because it tells me that they've got really high right atrial pressures. So it's not going to be your classic HCM, but it could be RCM or ARVC. So those things might help you kind of say, right, I need to push and say, that's the one I need to investigate or not. The other thing that you can use is your cardiac biomarkers and use them as a screening tool for work out who you need to be more concerned about. And just like with dogs, there's loads of studies, all with different cutoffs. But IDEX uses a cutoff of less than 100, and I would agree that if it's less than 100 picomoles per litre, they're not likely to have clinically significant stretch of the myocardium. Whereas if it's above 100, it's possible that they have clinically significant stretch. But there are lots of cats that I see that are just a bit over 100 that are completely normal. And we know that other things will push it up, and sometimes it's just they're a cat, and that's why their value is higher than normal. But lots of systemic conditions will also push it up, so hypothyroidism, hypertension, azotemia, outflow tract obstruction. So we can see if we get a normal or low result, whether that's on the SNAP test or on the quantitative that you send off to IDEX, and it's normal, it's low, great. It's really unlikely they've got disease. But if you get a high result, you still don't know what's going on. Troponin, on the other hand, it can be a completely normal number in some cats with myocardial disease. But if it's elevated, that suggests that they've probably got quite significant cardiac disease. So I would suggest that you consider using both of them to screen your cats and using that combination. So, well, if they're both normal, great, I don't need to be as worried. I still can't tell for definite what's going on, but I'm less worried. Whereas if they're both abnormal, I think this cat needs more investigations. Radiographing cats, not my favorite thing to do. I think you can miss quite clinically significant disease with radiographs. If it's big, fine, you're going to pick up significant atrial dilation. The big problem is that you're going to probably need to sedate the cat to take a radiograph, whereas with most dogs, I think you can often get them to lie still long enough to take a lateral. I've never yet managed to get in a healthy, happy cat a conscious lateral radiograph. And if you're sedating them to take a radiograph to find out if they're safe to sedate, it feels a little bit going around in circles to me. So I very, very rarely, if ever, radiograph cats. So for me, if I have picked up the murmur and the owner wants to investigate, echo is always going to be the way to go. You can use lots of things on your history, physical exam, you can use biomarkers to try and screen them up and down and work out what's more likely. But if you get to a point where either you or the referral team has made a diagnosis of myocardial disease, you have to be aware that there are, again, systemic conditions that can mimic those changes. So hypothyroidism, hypertension, acromegaly and anemia can all either cause hypertrophy or chamber dilation, and it's something that I keep in mind when I'm scanning these cats. Could they have a systemic condition that I need to treat? So if I have got a cat in front of me where I've made a diagnosis of myocardial disease, I want to measure their blood pressure because that's a nice, easy thing to do. It gives me a feel for how they're coping, but also allows me to rule out hypertension. If they're older, I'm going to measure total T4 and an IGF-1 to try and rule out acromegaly. And I'll do that generally once they get to about 10. I'll measure that in all of those older cats. If I'm concerned that they look like they're a bit volume loaded, I'll check a PCV and see if they're anemic. Although often I think when they get to the stage where their anemia is causing echo changes, you can tell on physical exam. And then it's treat the underlying disease first. So treat the hypothyroidism, treat the hypertension, see what else you've got left. And for a lot of them, I think that we don't have strong enough evidence to start any cardiac treatment in these preclinical cats. Really, the only group of cats that I'm going to treat are the ones that have a big left atrium. And for those, I'm going to start clopidogrel to try and reduce their risk of thromboembolism. And I'm going to start monitoring sleeping respiratory rate in an effort to pick up heart failure. I always warn any owner of a cat that sudden death is a possibility, and I think we're really bad at predicting which cats are going to die suddenly. I would say with any cat where you've even got a vague suspicion of myocardial disease, you need to be cautious with fluids and alpha-2 agonists, and that's because cats are just a little bit more fragile when it comes to these things, and we can't tell often how bad their diastolic dysfunction is without doing quite advanced echocardiographic techniques. So I would generally be cautious unless I've had a full advanced echo, but particularly if I've picked up that they've got a big atrium. Finally, the in-clinic assessment. Do you need to, really? I've seen so many cats do fine at home and then sit in the waiting room and go into congestive heart failure. One of my worst memories is having an owner call me from a taxi on the way to the appointment because their cat had gone into heart failure on the way to see me, and that cat had been fine at home. So repeat imaging if you have to. The stage B1 cats where you're saying, okay, they don't have significant atrial dilation, yes, keep a track on them, see how they're doing. But really, if they've got a big atrium and we know that they're already on clopidogrel and you're monitoring them with respiratory rate, you're not going to change anything by seeing what they look like other than stressing them out and potentially pushing them into heart failure. So these are the cats I say, right, don't want to see you again. Give me a call when you're worried. So finally, let's just summarize what we've gone through. For left apical systolic murmurs, which are going to be the most common disease murmurs that we're going to hear in first opinion, we're thinking mitral valve disease or DCM. Echo is always going to be the gold standard for diagnosis, but your radiographs will help you assess for cardiomegaly and work out whether you need to start treatment. Your biomarkers will help you screen which dogs you're going to investigate further, but you can't use them to start treatment or not. And once you've made a diagnosis, you know that you're going to want to do pimabendin and start respiratory rate monitoring for either the stage B2 mitral valve disease cases or the dilated cardiomyopathy cases, and no treatment for the stage B1 mitral valve disease cases. For cats, murmurs are really common, and we're thinking innocent murmur versus myocardial disease. Again, echo is your gold standard for diagnosis, but if you can't do that, just assess, do they have a big left atrium? And your biomarkers might help you screen which cats you're going to want to investigate further. And if you get to the point where you say, right, they've got their stage B2, they've got a big atrium, think about starting clopidogrel and doing respiratory rate monitoring. But no treatment for the majority of cats that are stage B1, and obviously no treatment if they've got innocent murmurs. Thank you so much for listening and for staying to the end. I'm happy to answer any questions. I've also put our email address which is the cardio team at Langford. We're always happy to provide advice.
That's great. Thank you very much, Rosie. Delegates, if you do have any questions, then please do send them through. We'll take a couple of minutes now. So we've got a few coming through here, if you're happy to answer, Rosie.
Yeah, absolutely.
The first one that I've got is, if a DCM dog doesn't have a murmur, are you likely to be seeing symptoms?
Sadly, yes. I have seen some dilated cardiomyopathy patients be in congestive heart failure and have a completely normal auscultation. And it depends entirely on the individual, how much their atrium has stretched versus how much their ventricle has stretched, how competent their mitral valve is. So you could have a really advanced DCM patient where they've just got a very good mitral valve and it's managed to keep a good seal, and they'll go into heart failure and never have a murmur.
Okay, thank you very much. So we've got a couple of questions here on sedating cats and dogs, if you need to, for an echo.
Yeah.
What would be your choice of drug?
So I am super lucky in that I often don't need to sedate because I have a nice quiet room and I have helpers. But I do sedate cats and dogs for echo, and I recognise that when you don't have the luxury of that beautiful room, you do need to sedate. I still try and keep, even if I'm not in an optimal situation, I'll try and keep the area as quiet as possible. And butorphanol, if you can get a catheter in and give it IV, so I often go 0.2 or 0.3 mg per kg for butorphanol, and for some animals that's enough. We have what we call a hypothyroid cat protocol, where the hypothyroid cats that come through for radioactive iodine screening at Langford all get echoes, and a lot of them, as you can imagine, are not amenable to being handled and restrained for a complex, complete echo. And so for those cats, it's an off-license combination. So it's a combination of butorphanol at 0.2 or 0.3 mg per kg, midazolam at 0.2 mg per kg, and alfaxolone, which is the off-license bit, at 2 mg per kg IM. And if you wait kind of somewhere between 5 and 15 minutes, you'll have a cat that goes completely flat with minimal cardiovascular depressant effects. And then you'll get an IV catheter in, and you can top up with alfaxolone, and we can get a complete echo. If it's somewhere in the middle with dogs, sometimes I'll do butorphanol and a low dose of ACP, or butorphanol and midazolam. Either of those are fine, and I would think about the rest of the patient as to which combination I use. I've had 2 dogs get hyperactive on midazolam, so I'm a little bit cautious with that. But none of those will have significant cardiodepressive effects. So you should still get a good feel for what's going on.
That's great. Thank you very much. I think that's answered a few of the questions that we've had come through, actually. So that's lovely. Okay. We do have a couple more. One that says, does gabapentin affect echoes in cats?
Great question. I love giving gabapentin we've got very much to a stage where if we've got anxious cats and we know that they're coming in, we recommend giving gabapentin a couple of hours before the echo. There was one presentation at the ACBIM forum, not this year, but last year, which suggested that it didn't have significant effects on cardiac dimensions. And it's certainly not going to change your decision-making process. The changes are so subtle that, if gabapentin, if you can get the cat to take it a couple of hours before the echo and it's relaxed, that can really help without having any significant effects.
Fantastic. Thank you very much. We've got another one here that says, can you just confirm, did you say that dogs don't have innocent murmurs?
No. So innocent murmurs in dogs are not left apical. So if it's a left apical murmur and you're convinced that that's what it is, then it's not innocent. But dogs do have innocent murmurs, but they're going to be up at the base, which is why it's really important when you're doing your auscultation to go backwards and forwards, up and down the chest, and work out, is this murmur more obvious at the apex? Is this murmur more obvious at the base? Because if it's at the apex, then it's not innocent.
Right. And just one more question here that we've got through says, what resting respiratory rates do you consider abnormal in cats?
We tend to talk about sleeping rather than resting respiratory rate. So we talk about sleeping as less than 30. I think a resting respiratory rate is normally about 5 breaths a minute faster than a sleeping respiratory rate. But I try and train owners to do sleeping rather than resting. I know it's difficult, and I think some cats, the minute you go into the same room as them, wake up from their sleep if they're a bit anxious. So owners have to do resting.
Yeah.
And in those cats, I get owners to learn what normal is for their cat. And actually, that's for both cats and dogs. Knowing what normal is for that animal is really important, because for some animals, 12 is normal, and for some animals, 28 is normal. And if that's the case, well, if that animal with 28 goes to 32, that's not a big change. It's not so worrying. Whereas if that animal that was normal is 12, goes up to 32, that's a big change. So owners learning what their pet's normal resting or sleeping respiratory rate is really important. But it's important they don't mix the two up, because they are different.
That's absolutely great. Thank you very much. I think that's all we've got time for this afternoon. So we'll leave it there. So it just leaves me to thank delegates very much for attending. and Rosie, thank you so much for such an interesting talk. And we'll say goodbye. Thank you.
Thank you. Bye-bye.
Thank you. Bye.